Dr. Lee Schmidt is here, and I believe a patient of Dr. Schmidt's as well, who's also a doctor.
I think we're talking the doctor first and then the patient. Right. And we're talking about something that I thought was the Equal Rights Amendment for a while there, but you're a specialist in Enhanced Recovery After Surgery, or ERAS.
How do you say ER? I mean, is there a way you say ERAS?
ERAS.
ERAS. All right, I knew there would be.
Look at that.
More show and tell.
That's all right.
No, and just because I knew that you guys would want to sample our ERAS ClearFast, I brought one for each of you.
All
awesome.
Right. Cool.
This is like a...
Do we drink it now?
It's like a cool Pedialyte, or what is this?
It's the
electrolytes?
It's the delicious drink that we give to all of our patients to take prior to surgery to help prevent dehydration and improve their nutritional status just before surgery.
Wow.
Is it as delicious as the stuff I take before a colonoscopy?
It's twice
Love that
delicious.
stuff. So if I have to stop eating before or after midnight, I can still take this before I come in, or?
So in the old days, we told patients that they were not allowed to eat or drink anything prior to midnight. And the idea behind that was so that patients would not, if they were to get sick at the time of surgery, would not vomit, and that would cause a problem. And what we've learned over time is that we can relax those rules so that now we allow patients to drink right up to clear liquids, at least up to 2 hours prior to surgery without trouble. But the ClearFast drinks are supplements that we give to patients that help prevent dehydration and provide better nutrition. So what we've learned over the years is the better shape we have patients in prior to surgery, the quicker they recover after. And ERAS stands for Enhanced Recovery After Surgery. And what really it entails, or it was developed, is to better help prepare patients prior to surgery and to speed their recovery. And just to put it in perspective, in the 1980s, patients that had a knee replacement or a hip replacement were in the hospital for 2 months for 2 weeks after their surgery to recover. In the 1990s, we were proud of ourselves. We cut that back to 1 week. In the first decade of the millennium, we were down to 4 to 5 days. Now, patients are out of the hospital within 1 to 2 days following hip or knee replacement surgery in most cases. And while some of those benefits are because we now do surgery in what we call minimally invasive techniques. That's certainly helped. Implants that you alluded to earlier are better. They perform and function better. They last longer. That helps. But what has really changed things in the past several years is how we prepare our patients prior to surgery and what we do for them in the hospital. We get people up immediately now. And so the ideas behind the ERAS protocol are what are all of the things that we can do to prepare patients so that they're in better shape on the day of surgery, and how do we get them up immediately after surgery and out of the hospital within the next day.
I want to properly introduce you because I don't think we did that, but Dr. Lee Schmidt is the Chief of the Division of Orthopaedics and Director of Joint Replacement Center at GBMC. So.
Thank you.
So he knows what he's talking about.
But
that's why we have him here.
Isn't recovery by its nature in the hospital? Aren't you enhanced? I don't understand the enhanced part of it, unless you give me an app that I put on my computer.
Well, no, I could, and I think at some point we will be handing out the apps. But so in the past, years ago, patients would come into the hospital. They could be dehydrated, as you alluded to, because they've had nothing to eat or drink after midnight. We do the surgery under a general anesthetic, and then we give patients narcotics to control their pain. And then because they're in pain, they're recovering from anesthesia, they don't get out of bed until the next day. They have side effects to the narcotics that can cause nausea, vomiting, sleepiness, constipation, all kinds of problems. And so as we've tried to get away from narcotics, we've found other ways of managing pain that enables us to eliminate most of those side effects. And when we eliminated most of those side effects, we found that we could get patients up right away after surgery. So ERAS really is a protocol that we've developed where all of the little things that we've found were improvements over the years, we've put them together in a protocol, and we call it enhanced recovery after surgery.
That's wonderful.
So, for example, if you were to come into the hospital to have your knee replaced, so that day, the day before, you're taking our nutritional supplements and so forth. But on the day of surgery, in the past, we would do a general anesthetic or a long-acting spinal anesthetic. Today, frequently, we will use a short-acting spinal anesthetic. And then after surgery, rather than relying on narcotics for pain management, we'll have our anesthesiologist do a nerve block prior to surgery. So in the case of a knee replacement, we'll put a needle in just above the knee and put in a long-acting pain reliever that gives pain relief that lasts for typically 2 to 3 days. It's up to 72 hours. And then after I complete my surgery, then I'll put a cocktail of medications. I like the word cocktail.
Yeah.
But I'll put a cocktail of medications into the knee.
But don't use them with a cocktail.
No. But I'll put a cocktail of medications into the knee so that when patients wake up after surgery, generally they don't have pain. So because they don't have pain when they wake up after surgery, and they don't have lingering effects of a long-acting anesthetic, patients can get up that afternoon after surgery and begin their therapy right away and not need to rely on narcotics to control pain.
So it sounds like this is a sort of a twofold benefit. I mean, you did this for reasons because it works well and also because you're trying to be more responsible with the opioids.
Exactly. So all of us have made it a concerted effort to try and minimize the use of narcotics in our practice. As we all know, the opioid crisis has been a terrible disaster for the country, and any way that we can avoid using narcotics, we should. And certainly recovery from surgery, one of patients' biggest fears is having pain after the surgery. So if we can relieve the pain better, and we do, and we can do it without narcotics, then that's to everyone's benefit.
What do you use in place of it, acetaminophen? Or?
No, so we use what we call multimodality pain management. And so that combines multiple non-narcotic medications. So there's Tylenol, there's anti-inflammatory medications. We use Celebrex. There are other anti-nausea medications. There's dexamethasone, that's a type of steroid that prevents inflammation from getting started. There are patches that we put behind the ears, like what people use when they go on a cruise to prevent seasickness. So those are the types of medications that we use.
And the pain block gets you over the hump.
And then in addition,
yes.
It's the pain block, it's the cocktail, and it's, as we say, multimodality. But all of those things together really allow patients to get started much quicker, much sooner, with much less side effects.
Would there be a use of medical marijuana in the future?
So I have certainly had patients request that.
I'll bet they have.
And well, they should.
But
whatever it takes.
It is not something I prescribe or use.
Okay.
At this point.
At this point.
All right.
So ERAS was developed at GBMC?
No,
it's developed nationwide, but you've
Right.
adopted it here.
Correct.
Okay.
Right. So ERAS is just what we call the enhanced rehab processes, and I think more and more hospitals are finding that this is something that they use, and it's used not just in orthopedic surgery. In fact, in our hospital, it started with colorectal surgery, but now it's being rolled out through all the different service lines because it's something that can be used in all surgeries.
Is this something that can be used on everybody, or are there only certain patients that can have ERAS?
No, generally, this is something that we plan to use for everyone. Everyone can benefit from the protocol that we use.
I imagine this is very comforting for a lot of patients who come in for the first time, because I think we've all heard the stories from years past, my mother included, who wanted me to ask you, I've heard that people, there have been instances of people dying after hip replacement, and, these horror stories, and it makes them fearful for coming in and actually getting, and so it must be so comforting to you to say to them, and how often do you say to them, oh no, we don't do that anymore, that doesn't, you will not be in the hospital that long. I mean.
So there's two sides to that. You are absolutely right in that it's comforting to patients to know that they're not going to wake up from surgery in terrible pain, and that's comforting. And because we have patients mobilized so much quicker, the complication rates are way down. We don't see blood clots hardly ever anymore. And
infections.
Right. All of those things are exceedingly rare. But we still tell patients, for example, after knee replacement surgery, you still need to do the rehabilitation work afterwards. You know, the first 2-3 days are much better, and that gets you over the hump. But after all of those, the nerve block, the cocktail, etc., wears off, then there is still discomfort, and you still have to work through that. So it's not as though we've eliminated all the discomfort in recovering from knee replacement surgery, but we've made it much, much better. And again, we found when we get people over that hump, once you're sort of on your way and you've gotten started, they do so much better and recover quicker. But it's not a walk in the park.
Are there bad reactions to your cocktail?
I can't say that I have seen one. I'm sure someone will have an adverse effect, you know, some sort of allergic reaction that we couldn't predict. I'm sure it will happen.
Or they don't manage their pain when they get home.
Right.
You know, because pain is about managing it, right? I mean,
and still, you know, patients can have bleeding after surgery. They could go home and have bleeding and swelling and have more pain, and things like that can still happen. It's just that it happens much less often because of a combination of less invasive surgery, less aggressive anticoagulants, and so forth. So it still happens, but it's...
I know surgeons spend a lot of time standing up and working bent over on patients and things like that. Have you had anything replaced?
Not yet, but I do still snow ski, so it's going to happen sooner or later.
Yeah, don't try snowboarding. I just can't tell you that.
I'm too old for that. Right.
Well, I thought I wasn't.
The shoes are more comfortable, though.
They are,
Yeah.
exactly, and it's one board. It is easier. Okay, so I know a lot of people, too, who almost had, it's sort of like it was a badge of honor for them to get the double knee replacement.
Mm-hmm.
I mean,
At the same time?
Yeah, people come in and say, should I get it done at the same time? Like, I would be inclined to do it both at once, but what are your thoughts on that?
I should have brought my other partner with me. I replaced both of his knees in September, and he could probably speak to that issue better. No, it's something I do fairly frequently for patients that have both knees that are bad, that are going to need to have them both done. There's two sides to the coin. One side is people say, look, I don't want to take the time of going through this twice. You know, I'm afraid if I only do one, then I won't want to have the other one done. And so for a highly motivated patient who doesn't have any severe medical conditions, yeah, I think having both knees done at the same time is a great option. And I do probably 3 patients a month where I do both knees at the same time. On the other hand, statistically speaking, there is a slightly higher risk of a complication when you do both knees at the same time as opposed to just doing one knee. It's small, but not zero. So if patients have significant medical problems or medical issues, then I don't recommend doing both at the same time. But years ago, when I first started doing both knees at the same time, I had the fear that patients would have more difficulty trying to rehabilitate,
right,
starting with both knees at the same time. You think, oh, I'm not going to have a good knee to stand on. And then I was surprised when we looked at the outcomes data. Oftentimes, those patients did better than my patients where I only did one knee. Now, maybe that was because I only selected out the best patients to do both knees on, and they were highly motivated, but no, I've not found that to be an issue.
But a double replacement patient can stand as quickly as a single replacement?
So when I do both knees Monday morning, by Monday afternoon, they're up and they're walking.
That's
doing
incredible.
Therapy.
I don't believe you.
And
wow,
on Tuesday, they're skiing with them.
Wow.
And then the block wears off on Wednesday.
Right. So I had a block on, I broke my wrist a year ago, and I had a block on my arm, and so for good more than 24 hours, it just felt like a piece of sausage. I mean, I had no feeling.
This is different.
And that scared me.
Right. So you're right. So when we first started doing the nerve blocks, we would do the nerve block up higher in the leg, more in the groin area, and it would cause a larger area of numbness and would cause weakness in the leg. And occasionally we would have patients that would fall because the leg would give out. Mm-hmm. And so we refined the technique so that now the nerve block is given just above the knee. And the only area where there's some tingling or numbness is around the knee and just below it. But it no longer causes the muscle weakness, and you don't get that dead arm kind of feeling. Because if you had that, you couldn't get up right away and begin
No, you could not.
therapy.
You brought us some show and tell, and I've been staring at this lovely chrome, whatever it is.
It's a beautiful knee.
Right?
Yeah, I mean, that is really neat. I'd ask you not to put the skin bag over it.
Right.
What is that? Is that a knee?
So, yeah, so that's a full knee replacement, what we call a total knee replacement. And can you hold this one?
Yes, absolutely.
So many people have the idea that when we do a total knee replacement is that we just cut out the entire knee and replace it. And that's not what we do at all. What we really do is just replace the surfaces. So this is the model of the knee. We trim away the damaged cartilage on the end of the thigh bone and replace that with a metal cap, the way a dentist might put a cap on a bad tooth. And then on top of the shin bone, we trim away the damaged surface and replace it with a metal tray with a plastic cushion. So instead of bone grinding on bone, it's the metal on the plastic. And then in addition to that, we put a new cushion on your existing kneecap so that all the surfaces in the knee are replaced, so you can never get arthritis again. And so this is called a total knee because it replaces all of the surfaces in the knee. And that's opposed to a partial knee where we only replace one compartment in the knee. So this is an example of where we just replace the cartilage on the inner side of the knee for patients that only have arthritis in one compartment of the knee. This shows a mobile bearing knee that's got a little mobile bearing.
But if you're prone to arthritis in your knee and you may only have arthritis in one compartment, wouldn't it maybe stand to reason that you might develop it in the rest of the knee, and why not just go for the full total knee?
Right, so this is a great question, and it's years ago when I first started doing knee replacements, I trained in a center where we did a lot of partial replacements. And when I came to town, there weren't many people doing it, but suddenly they became very popular, and surgeons started putting them in for all kinds of patients. And years ago, they were given a bad reputation because many of those patients had pain afterwards or they failed early, and it was because of improper patient selection. And so if you're going to choose an ideal patient for a partial knee replacement, it should be someone that you do not think is going to have progression of arthritis throughout the knee or already has arthritis throughout the knee. So a partial knee is clearly not for everyone. Proper patient selection is key.
And I really am a Scotsman, so is a partial cheaper than a full?
So oddly enough, this partial replacement here, this is a mobile bearing type of knee. It is almost the same cost as this one.
What a deal.
Oh my gosh, go for the full.
Yeah.
So, yeah,
I bet you that full would work better than my knees work now.
I don't think so.
Okay.
And the shiny material is titanium?
So that's a great question. So the shiny material, you mentioned chrome, so this is actually chromium cobalt, because chromium is a very good bearing surface. So most all of the component that goes on the end of the thigh bone are chromium cobalt, although we also have implants that are made of either ceramic or a specific type of titanium for patients that have metal allergies. And then on top of the shin bone, this is titanium. This is a plastic model, but the real one is made of titanium. And then the bearing surface, what we call the plastic, is polyethylene, and it's called ultra-high molecular weight polyethylene. And I don't know if you can see it or not, but this one is discolored or yellowish. The reason for that is it's vitamin E impregnated, and it's one of the advances that you alluded to earlier, that vitamin E is an antioxidant, and one of the mechanisms that knee replacements can fail over time is the plastic or the polyethylene can oxidize, and when it does, then it can fail prematurely. So we believe that by impregnating the plastic with vitamin E, that it will reduce or eliminate that oxidation, and we hope that these will last much longer than the generation before them, but we won't know that for sure until we follow these out for another 20 years.
And we boomers want to know, can you get granite? like your granite tabletop?
I bet you could get whatever you want, but the question is whether or not that would be good.
All right.
Getting it and wanting it and needing it.
We have a question.
Are you dinging security when you walk through?
Absolutely.
Yeah.
Years ago, we gave all of our patients a card that says, had a picture of your knee replacement so that you could use it going through airports and so forth. And probably 9 or 10 years ago, TSA asked us no longer to do that because patients or anyone would come through with a card and say, no, you don't have to wand me, and so they told us not to do that. So now everyone needs to go, and when you arrive, tell them you have a joint replacement. I'll take the wand and we'll wand it just to confirm that.
And if you try to go through the big machine or whatever, they'll take you off to the side and wand your knee. But
right. So usually you'll look for the most attractive TSA agent and have them.
I guess
so you'll be able to walk through the airport easier, but it may slow down your travel just a hair.
We have a question?
Yes, we've got a few questions coming in on Facebook. The first one is from Bonnie, and she asks, what is the recovery time?
So let's say knee replacement surgery, because of knee replacement, maybe the recovery is a little longer. And so let's just take you through a scenario. If you come to the hospital Monday morning, and I'm going to do your knee replacement Monday morning, so you'll come in, you'll have the surgery done. That afternoon, you'll do your physical therapy, you'll be up, you'll be walking. Theoretically, we can send you home that day if we wanted to. I generally keep most all of my patients at least overnight into the next day. The next day, you do more therapy. Make sure that before you leave the hospital, you need to be able to walk laps around the joint replacement center, do the things you'll need to do at home to take care of yourself, go up and down stairs, assuming that you have stairs at home. And then when you go home, we either send a therapist to the house, or alternatively, you can begin outpatient therapy. You're allowed to put full weight on the leg immediately. Most people will use crutches or a walker for a week or two, a cane a week or two, although some people find that they can be off of that within a week or two. I have some patients that own their own business that feel that they can't be out of the office at all. They go back to work the next week. I don't recommend that, but they do that. Driving, somewhere between 2 to 4 weeks for most people. Some people do it sooner. I'm not sure that's a good idea. For patients that have a desk job, I ask them if they can to take off a month, because I prefer that they use that time to spend rehabilitating their knee. In patients that do manual labor, it's going to be 2 to 3 months to do that. Wow. For patients who do well, they're playing golf at 2 months. So there's variability.
What happens, and how often does this happen, if a patient feels good, oh yeah, I'm walking, I don't have any pain anymore, and they kind of stop the physical therapy? Right. Have you then limited now what this knee can do for you?
So the hard part after knee replacement surgery is regaining the motion in the knee. And different patients form scar tissue at different rates. And that's the one thing that we can't control. The thing that we can control is doing the surgery well, trying to prevent bleeding and swelling, and motivating patients to work diligently in therapy to maximize the motion. And some patients form very little scar tissue. They only have to do physical therapy for a few weeks, and then they can do it on their own and they're fine. Other patients whose body tends to form a great deal of scar tissue can struggle and may need 2 to 3 months for the knee to settle down to maximize their motion.
And they also work to break up the scar tissue, right? Is there a massage aspect to it?
So for some patients, the therapy is really necessary for 2 to 3 months, but for others, they can get away with 2 to 3 weeks of therapy and then do the rest on their own. And I do have patients that choose to do all the therapy on their own, and many of them do fine because they're motivated and their bodies don't form scar tissue, but we insist on the therapy at least for a month.
Okay, we have another question, and then we're going to bring one of your patients up. I don't know if we're going to switch off or if we're going to add her to it. Switch off, okay. The question is?
So she's going to come and tell you what actually happened.
Yes.
Yeah, what the real deal. And you're going to leave the room.
Yeah, I'm leaving.
Question.
Perhaps I can ask a business question. Given the improvements in the replacement devices and in the technology surrounding medicine in general, I happen to have a brother who's an orthopedic surgeon. I'm just curious whether you've seen a benefit to the cost of your malpractice insurance.
So, we've been fairly lucky in terms of malpractice insurance. I think that it's mostly related to whether or not you've had problems in the past, and because of being very fortunate with that, that I think is why our rates are low. But I don't think they've changed much over the last 20 years for us. I don't think they've gone down, but the fact that they haven't gone up is, most things have gone up, and so I guess theoretically, cost of living wise, they've gone down.
I remember Maryland living through a malpractice
You will always
insurance
have,
crisis.
Yeah. You will always have a job.
That's true.
That's true. All right, we're going to bring up Dr.
Dr. Schmidt, thank you so much.
Pleasure. Thanks
Dr.
so much.
Lindsay Whitby. She is a doctor. Linda, I'm sorry.
Didn't drink your...
Well, not yet.
Oh, no,
I thought we were supposed to do it in front of you or not, but Dr. Linda Whitby, who is a patient and a doctor, but not an orthopedist, I trust.
I don't know, maybe, but we want you to run up here and do sort of high knee bends, a couple squats.
Oh, you do a little. Oh, that's for this.
Dr. Whitby's coming up here.
Hello, Dr. Whitby.
Hi.
Sorry, I messed your first name up, but first time around. How recent?
Here she comes. Did you just have this done?
Almost a month.
Wow.
okay.
1 month out.
And 1 knee or 2?
Just one.
Okay.
Were you cringing when we talked about having the double?
I'm
I'm going to let you hold that.
one of the bad patients. I let a bad knee drive me crazy for forever.
Because you're a doctor. That's why
that
you're a
what
bad
it was?
patient. Yeah.
Just pull the mic kind of close to you, like almost lipstick, but not that close.
Okay.
Okay, you're a patient, but what kind of a doctor are you? And are you a doctor at GBMC or private practice?
I'm OBGYN down in Southern Maryland.
Oh, great.
And here in Baltimore for a couple of the systems up here.
Wonderful.
And how bad was your knee? How long did you let it be bad?
20 years. I was
What?
in a car accident, and the people I was seeing told me I just had to learn how to live with pain, and chronic pain does drive you crazy.
Mm-hmm.
And I had to keep working, so I managed to get fractures in my tibia plateau. So when I got to a point where I couldn't ignore it and the knee took over my life, I didn't have a choice. And that's when I found out how old I was, how out of shape I was. And now doctors are penalized because their patients don't show up optimal. And so December a year ago, I had to have bone grafting because the orthopedic guy I went to, who was very good, he took time to explain to me that somewhere over time I turned into an old person who happened to be diabetic, hypertensive, and 80 pounds overweight, that I wasn't an optimal surgical candidate, which led me to GBMC. But it's been an interesting adventure. And so I'm here today because I want to encourage people that this is the only costume we get. And if you don't take care of it, and because we take care of so many other people, we always take care of ourselves last. And we need to switch that around a little bit.
So, you talked about, but you don't look like, you look like you've really gotten your health together in many facets over the last year. Is that accurate?
Yes.
So was it just a huge wake-up call?
It was a big, big wake-up call. If you asked me 3 years ago, would I go have bariatric surgery, I would have laughed at you. I'm not in the market anymore. I could care less what I look like. But I needed to, I needed to walk. Not being able to walk was a problem for me.
Well, if you're an OB, you're delivering babies, right?
Not anymore. I turned into an old lady.
Well, I was going to say that's a very physical job. I don't know if people realize how physical that is.
I was hit by a car. I used to fly airplanes and do crazy things, and I was in Florida for a day trip, and somebody ran into the back of us, and I was one of these goofy people who thought, I'm okay, nothing bad. Next thing I know, months later, I couldn't feel my fingers, spine issues, all kinds of stuff. But the knee was what took me out of business. I couldn't really function very well.
Right or left?
Right.
And before you had the knee surgery, were you using a cane or crutches or walker?
I'm too vain to use a walker.
Grocery store cart?
No, I can't reach the things in that stupid cart, but I had to actually, really work on my brain and do appropriate self-care and actually start getting on a scale and no longer buying donuts at the gas station, things like that.
Improving your quality of life. So Dr. Schmidt said he would operate, he would replace your knee, and so that must have been incredibly, you were probably afraid, and also very comforting that there was some hope, right?
Yeah, I didn't do very well with the bone graft, and I have to applaud GBMC from its volunteers to its staff. It's a great, great hospital. And we're in an industry era where this country is in bad financial shape, but this hospital continues to care about its community. And programs like this using social media make a big difference. And you guys are amazing what you give back to the community. I'm honored just to be sitting up here.
No, we're honored to have you.
And I'm a volunteer at the hospital, so I thank you for that compliment as well. But I never got my answer. Did you use the cane before you had the surgery?
Oh yeah, I was falling down, doing all kinds of embarrassing things.
And you hope
know when you're a big, short lady, and you're
I know all about that.
Yeah, no, it's terrible.
But you see an end to that now?
Yes, I would have walked up here without it, but with the man here, I didn't didn't want to be too vain.
So I wanted to hold on to the million-dollar question, but now I'll ask it. Just describe how life-changing this surgery has been for you.
If you can imagine walking around with a rotten grapefruit between this bone section and this bone section,
wow,
and it's sloshy and all of that, I was really afraid that first day to get up. And I prepared for the surgery. I did quad exercises and this and that, but I was really shocked that when I got up that same day, I actually had stability. I couldn't believe it. That was amazing. I was determined to go home, no nursing home for me. And it was, the staff was incredible in terms of the physical therapy, the training, putting up with stupid questions. I mean, it was a very busy program. You don't get a chance to just sleep in 6 hours or anything like that, but it was fantastic.
The good doctor.
Confidence building.
The good doctor told us about it, getting patients out of bed the next morning.
The ERAS program,
yeah,
so you benefited from that.
When they came to you and said, okay, we get out of bed, we're going to go for a walk, the day after surgery, you said?
Day of surgery, and what I loved is that it didn't just happen that day of surgery. You had a class before you even, once you got scheduled, you had a class before surgery. So they introduced you to this wonderful
stuff.
I feel like we have to drink it now.
And you met the people that you were going to be working with. It was fantastic.
Do you want some? Come on. Celebrate old times?
I can't get mine open. I'm sorry.
All right.
Do we have to shake it first?
It's clear. That's encouraging. All right. What do you think?
Mystery fruit. What kind of fruit?
Well, that's pretty good.
What kind of fruit is that supposed to be?
Actually, that's pretty good. Wild watermelon. So this is, in case you're just joining us, this is the liquid that you can take now, I think 2 hours before you have anesthesia and surgery, which is a whole new thing, and it keeps you hydrated and hopefully aids in the recovery process afterwards and coming out of anesthesia, which can be tough for a lot of people.
It is not the cocktail the doctor injects.
So this has been incredibly life-changing for you. This is
yes.
So when you talk, if you hear someone who said, "Oh, my knee's been bothering me for years. Oh gosh, I've been thinking about it. I'm too afraid to go ahead," you just say, "You've just got to get it done." I mean,
well, you encourage people to talk to people who've been through it. I was at a restaurant on the Eastern Shore, worked there one day a week, and this little old lady saw I was struggling, she came up to me and she started marching with her knees up in the air. She says, "You really ought to go do it." It was really cute.
That's a sign from God right there.
It was.
Now, how's your other knee?
Not bad. Not bad at all.
Okay, so knock on. I think that's wood.
Any other procedures that you've had?
Oh,
Orthopedic?
yeah, I've had bilateral
Carpal tunnel?
Right,
Okay.
all from that fall car accident, and
Wow.
it was pretty exciting. And all of it was late, you know, because again, we think that the body is going to heal itself, and it pretty much does. But when you find that you've lost your range of motion, you can't put your arm in and lift that baby's head up.
Yeah.
Yeah.
How nervous were you, 2 days ago when we had a sheet of ice on the ground?
I did not go outside.
Good for you. The old you probably would have, right?
Yeah, because I was one of those, if anybody's going out, I'm going out, you know. Yeah, I'm that old ER doc.
But your hips are yours, your shoulders are yours.
All mine.
Very good.
All mine.
And you're all heart. Thanks so much for being here and sharing your
It's
story.
an honor to be here, and keep up the excellent work. You guys are amazing, and our community really needs these kinds of things. So I applaud you.
All right, we'll come back anytime.
Yeah.
Thank you.
You can stay there. You don't have to get up.
Thanks so much to our audience for
Yeah.
being here. And
Well,
great
great
questions
questions,
today. And we'll see you next month on Facebook Live.
Yep, February 14th, which has a familiar ring to it.
Don't forget your sweetie.
Maybe we'll be doing something on Valentine's Day. Who knows? Heart bypass. There's a Valentine for somebody. So again, thank you very much. We'll see you next month.
You guys.
Cheers.
Beautiful. Personality.